So the sort of things I'm going to cover are partly to do with the aortic arch, where I'm going to classify this as wrong size, and vascular rings, where I'm really looking at wrong place. I'm going to take a very close look at the four-chamber view and look at some abnormal connections and some subtle abnormalities. I think it would be a really big mistake of me to try and cover everything in 13 or 14 minutes. So I'm going to try and pick out selected examples and then field questions as we go through. You'll be aware, if you look at the image on the left, is the sort of anatomic image of looking at a left-sided aortic arch. But as Monique has already shown, this tends to be the sonographic cut we take with the three-vessel trachea view with the SVC here, the transverse aortic arch, and the left-sided duct. And normally the aortic arch is to the left as well as the duct. And if we look at the sonographic equivalents of those, we actually mainly, I guess, do this by eye, is we're now seeing the right ventricle, pulmonary valve, and duct. We now see the transverse aortic arch, and these vessels come together in a normal V, with the trachea here outside of this V formed between those vessels. And just to emphasize what Monique said again, in descending order of size, you can see from the duct, transverse aortic arch, to the superior vena cava. And one of the areas which we're particularly concerned with is looking at the distal aortic arch, because this is one of the areas which we use to judge coarctation of the aorta. We prefer, from a screening perspective, to use this three-vessel trachea view because the aortic and ductal arches are in different planes, and if you're to compare their size, you really need to use a transverse approach rather than the longitudinal or sagittal planes. With respect to coarctation, you may get a clue from the relative size of the ventricles, and here's some examples with right ventricular dominance in all of these upper planes. And now if we look at the size of the great arteries, we can see dominance of the ductal arch compared to the transverse aortic arch. But note, there's a very high degree of overlap between true coarctations as proven postnatally and false positive cases, which we're all familiar with. And that is one of our biggest problems, is trying to work out what is a true positive case and what's a false positive case. And I'm going to give you some tips about this. You may also see, you see this discrepancy, that very often, though there may be bilateral superior vena cavas, so you don't just see one SVC on the right, but another one here over on the left in a couple of these examples. But this is a very important lesion for us to predict clinically, as its prenatal diagnosis is associated with improved outcome. Now this is a really, if you look at the top right here, it's a really nice image from Andrew Cook, where he's looked at casts of the fetal heart. And I want you to look at the normal fetal arches, where you see the duct insert really into the side of the aortic arch, whereas in coarctation, the aortic arch is more inserting into the side of the arterial duct. And although some fetal coarctations may be relatively discrete, the rule is more that there is a degree of hypoplasia. And this is the hypoplasia which we appreciate on the three-vessel view. So although our screening view may be using three-vessel trachea view, there is some benefit to look at these longitudinal views. And we see here very nicely the transverse aortic arch with the ductal arch underneath, and this very narrowed area of the isthmus, the distal aortic arch, inserting more into the side of the ductal arch. And just looking at the grayscale image here, again, you see this really important, if you can see it, in terms of the ductal isthmal junction. You see the size of the duct and the distal arch here. And note with this vertical orientation, this isthmus, the true isthmus, may actually fall out of the plane of the three-vessel trachea view. This is what we more do in practice, is actually look with sweep. So we go from through here, from the ductal arch through to the aortic arch, and note the size discrepancy here. And then we go on to look to get further information, looking on color flow at the anatomy of the ductal isthmal junction. So again, I would really encourage you to look, if you do suspect an abnormality, to not simply rest on the 3-vessel trachea view, but it's very helpful to get additional views. There are an absolute multitude of studies looking at predictors of coarctation, and probably it's the lesion which most fetal cardiologists feel most uncomfortable about. I'll just point you to some recent data from our group, from Trisha Vigneswaran, which are based on prospective rather than retrospective data on well over 100 cases, where we're looking at the chances of there being coarctation being related to both the Z-score of the transverse aortic arch and the arterial duct. So with a bigger arterial duct versus very small transverse aortic arch, you get your highest percentage chance of coarctation of the aorta. But if you look at all these numbers in all the panels here, you'll note that none of these numbers are 100%. So I think in most people's book, this is a lesion which remains to be confirmed after birth. Some of the things we're looking at, and I'll show a few more pictures later on, are now with our motion-corrected fetal cardiac MRI, we can get really novel insights into the anatomy of the aortic arch. These are fetal cases. And this is looking from the back, looking at the size of the distal transverse arch and the ductal arch. And we're looking at this extensively to see if this can actually give us some better predictors of postnatal coarctation. You note here the end to side anatomy of the transverse aortic arch. And there's really a multitude of examples here, and I'll stop there. Otherwise, we'll just look at coarctations all evening. Now I'm going to move aside where we've looked where the aorta is, if you like, the wrong side, to look at vessels which are in the wrong place. And these are really being seen far more frequently because of the introduction of the 3-vessel view, 3-vessel trachea view. And I'm really only going to cover some of the commoner variants and a very brief discussion of the implications. These are the sort of things that we're looking at. First, we have the normal left arch and left duct, which you'll be familiar with. The next group is the right aortic arch, so passing to the right of the trachea, with a left-sided arterial duct. Very frequently, there will be an aberrant left subclavian artery. And you can see the net effect is that there is a ring encircling both the esophagus and the trachea. So we're bothered about this because of the potential for the compression of the esophagus or trachea or both. And in this example here, we have a true double aortic arch with the right arch to the right, left arch to the left. So a true blue textbook double aortic arch with the same effect or similar effect of compression of the esophagus and trachea. In a study we published recently looking at background population, these are the sort of incidences we found of isolated right arch and double arch. And of note is that with isolated right aortic arch, we found a 5% incidence of 22q. So aside from the compressive effects, we're worried about associations. And there's quite a lot of controversy and argument about the moment about the precise degree of that relationship. But certainly in this series, the incidence was around 5%. So let's start by looking at right aortic arch with left arterial duct. So when you look at this, what you're seeing, this is a view of the upper mediastinum. You're seeing the SVC. You're now seeing the right aortic arch, a left arterial duct, and the trachea is now between these vessels. So this is the right arch, left duct, and this makes, rather than a V, a U shape of these vessels where those arches meet behind the trachea. And if you look at this with color, here's another similar example where we're showing a right arch, a left duct, the trachea is between the two arteries, and posteriorly here you can see the late arising aberrant left subclavian artery. And this is often best seen early in gestation rather than late in gestation. And you can see their labeled diagrams to the right here. Double aortic arch usually has a dominant right arch. are usually symmetrical head and neck vessels as you scan upwards, and again with a similar effect as we've discussed. So here what we're seeing is a right arch. So you have the SVC, a right arch, a smaller left arch, and a left pulmonary artery and duct. So if you like, you get a sort of four-vessel view. If you like, there's an SVC and then three arches to see. SVC, right arch, and left duct. And here's the color representation. And this is something, if you want a sort of pattern to look at, you see a sort of Z with the pattern that these arteries make, with the right arch, the left arch, and the left duct. And this is just a labeled of the same image. We've published some work recently, which I'll leave you to reference, to look at in terms of how we see these and implications for after birth. But very importantly, is that how these look before birth is not necessarily the way they look after birth. And what we see many times is we have a prenatal, this is again a fetal cardiac MRI, with the right arch, and left duct. But very often with closure of the duct, this left side of the aortic arch becomes atretic. So it can be falsely diagnosed, the appearances prenatally and postnatally look quite different. And this just shows some of the benefits of using the MRI technique to show the right, the left arch. And this left arch very often inserts in towards the duct rather than very posteriorly towards the descending aorta. This is a rare example, but something to watch. So this is the right of the fetus, the left of the fetus, and in this example, there is a right aortic arch as we come up here. And there's also a right-sided duct. So this is the right arch and right duct, and you'll see that the trachea is not between these vessels. So in this example, right arch and right duct, there is no vascular ring because the trachea is not encircled by these vessels. I'm going to move across, just rapidly across now to look from the outflow tracts towards four-chamber pitfalls, and just a kind of not quite random, but a selection of abnormalities here. So this is again, when Monique was talking about really looking for the first branching artery from the left ventricle, I really would encourage you to not just look that there are four chambers, but to really look hard at what those chambers are. So when you see here, we think will be the left atrium and this is the right atrium, and that would be correct. I've shown the situs shot here. But you notice that this chamber connects to a chamber, the atrium connects to a ventricle with a moderator band, with a more apical AV valve, and the more anterior ventricle connected to the right atrium is smooth-walled with an AV valve inserted further from the apex. So what we're looking at here is a left atrium to morphologic right ventricle and right atrium to morphologic left ventricle. And this is what we call discordant AV connections. In this example, the cardiac axis is normal, but very often in these cases, the axis is abnormal. The take-home point is to look very carefully, not just at which side ventricles are on, and not just their size, and look at some aspects of their features. This is important because this arrangement in its simplest form leaves the right ventricle pumping blood around the body, and this has implications for long-term prognosis. We published a recent series, large prenatal series on this, and I'll leave you to have a look at that if you wish. The next lesion I'm going to focus on is on atrioventricular septal defect or AV canal defect. And really importantly, this is if I'm looking from the ventricles up towards the atriums, that this is an atrioventricular septal defect is not just a hole between the atriums and the ventricles. The whole anatomy of the AV valves is wrong. So there are leaflets which bridge from the left ventricle across to the right, above and below here. So if you look only at the short axis of the left ventricle, you see an AV valve which effectively has 3 leaflets. Now this is easy if we look at a classical AVSD here with a big ventricular component, no septation of the atrium. But it's really important, if you can, to get some look at the short axis of the AV valves. This is an AVSD, where we see a common AV valve with leaflets bridging between the left and right ventricles. And in contrast, you see the normal left AV valve with a bileaflet left AV valve, and no leaflets are extending towards the ventricular septum. If we look at this example here, I bet everyone in this audience would say this looks like a perfectly normal 4-chamber view. You don't see a ventricular septal defect. You see what looks like a primum septum, and you pass this as normal. In other views, we queried the differential insertion, so the tricuspid and mitral valves, as we thought, are on the same level. But when you look at this in short axis, this is the same fetus, as I showed you with the apparently normal view. There is not a normal mitral valve. There's the anatomy of an AVSD. So this is an example where there is an AVSD with no ventricular or atrial shunts. Now, thankfully, this baby had already been diagnosed with trisomy 21, otherwise I don't think I would have spotted this. But it's a really important trap to not look at the short axis of these AV valves in cases of doubt. And a further case of doubt, which is confused with an AVSD, is this. It's where you have this view where it looks like you've got the normal crux of the heart, and you see this circular structure here. Now this is an enlarged coronary sinus, and this actual primum septum and atrial septum looks normal. But as you scan downwards, below the mitral valve, and really important to see that you don't see the mitral valve opening, to below the mitral valve, you see an enlarged coronary sinus, for which the usual explanation is that there is a persisting left SVC draining to the coronary sinus, and sometimes only a single left SVC draining to the coronary sinus. So watch out for that, and do sweep through your views to see whether you can find the coronary sinus, and if possible, get a short axis view of the AV valves to show that this is not an AVSD and is truly a mitral valve, but simply an enlarged coronary sinus. I know I'm moving around a lot, but next I'm going to look at pulmonary venous drainage, and I really want you to focus on looking here at the normal pulmonary venous drainage. You see veins from the left and the right draining to the left atrium. And really importantly, you can see that the left atrium is right up against the descending aorta. There's no real space there. And if you Doppler this, you'll see the normal phasic flow pattern of the pulmonary veins. So what about this example? On first glance, you might say this looks normal, but have a very close look at the back of the atrium here. And this is a slightly unusual appearance here at the back. You've got a sort of, looks like there might be a further chamber behind the atrial mass. And this is where I think really the combination of color and cross-sectional imaging comes into its own. Whereas this is the same case, we see the left atrium, and here we see the pulmonary veins not joining the left atrium, but coming to a confluence, which we see here, and is shown in the stills to the right. These veins come close to, but not draining into, the left atrium. And this is really important to check that you don't just see color, but you really do see these veins draining into the left atrium. And you should Doppler them, because sometimes with anomalous veins, you'll see that phasic pattern lost, particularly if the veins are obstructed. I don't have time to go into every single feature, but note when you come up in this example, same example, we see the pulmonary artery, the transverse aortic arch, and the SVC is now bigger than both the aorta and the pulmonary artery. And in this example, it's bigger because the pulmonary veins are draining above the heart, in supracardiac, total anomalous pulmonary venous drainage. And this is a good clue to that diagnosis. We now get, again, with the reconstructions, just to explain the anatomy, you see the confluence behind the heart. In this case, an ascending vein going up and then draining into the superior vena cava. So these type of reconstructions, they complement echo, they don't substitute for echo. So what we've learned here is really coarctation of the aorta remains a big challenge. Measurements can help stratify risk, but we've still got challenges there. In order to understand the three vestroventricular variations, you need to have a clear understanding of the normal appearances, and the right aortic arch can have implications for particularly tracheal compression and associated genetic abnormalities. If you see equal size atriums and ventricles, it doesn't mean that all is well. You need to look carefully at the morphology of the ventricles, look at the crux of the heart very carefully. If you're in doubt with AV valves, short axis views can sometimes help. Pulmonary veins are difficult even in expert hands, and you should really do your best to ensure that they truly drain into the left atrium and not close to it. Thank you very much for your attention.